Yes, this is the solar eclipse that occurred 10 days ago. This photo was taken from Abu Dhabi desert. So here was in Hafuf, actually it was picked up. So we can look into images and we can pick up the diagnosis. The same thing in LSSN. I can just send some photos to some of my colleagues in the United States, and I can take their opinion, in particular Dr. Carl Karp or Shields, and I can just communicate with them by just sending the photos and the images. This is the modern ocular surface diseases. So it can present with different way, morphologically. It can present as gelatinous mass, as you can see in all these pictures, or in papilliform, can be present in leukoplakic, where there will be a lot of keratin dominating the lesion itself. It can be multifocal with different foci, or could be nodular, different sizes. And by the way, all these images are from KKESH patients. And nodulars, again, you can see, can be a small, can be large. So the 1 million question, can we differentiate the dysplasia or CIN versus squamous cell carcinomas? Tell you the truth, 40% only of the experienced surgeons will be able to differentiate that one. This is the accuracy. The reason behind is that there are some variations according to the patients themselves. We'll discuss that one later, and also the region where the OSSN occurred. So, for instance, in Sahara in Africa, there are no unique presentations because most of their patients are HIV, almost like 70%. So they can present with any one of these features, and with different degree of invasion. There are, however, some certain signs that can tell you this is more towards squamous cell carcinoma in situ, like extensive leukoplakia, nodularity, papillomatous lesion, presence of large feeder blood vessels, scleral fixity. Scleral fixity, usually we notice that one intraop. We don't like to touch the lesion when we examine it. Raise, in order to avoid shedding of the tumor, raised lesions, temporally located or superior located lesions, and multifocal lesions. These will guide you toward suspecting the squamous cell carcinomas. What about the impression cytology? Is it of help? You can perform that one using a filter, apply it on the lesion itself if you have a good pathologist who can read it. The only thing is that there are no consistency about using this diagnostic tool. And to most of the ocular oncologists, that will tell you it's not very important. It requires an immediate analysis, extremely experienced pathologist. It doesn't help you in grading the tumor, and because it doesn't have the basement membrane also as well, may give you only the superficial dysplastic cells, and underneath it's cooking down with invasive lesion, and it's again, it's a tissue. It's an issue of what you call controversy. Even in the literature, when look to the evidence-based, the largest two series, some of the ocular oncologists, they said yes, we can differentiate with the help of our pathologists between the squamous cell carcinomas from sign, and these are the list, and the others they would say, and with high sensitivity specificity. Other pathologists, they will tell you that we cannot differentiate. There is no way that you can differentiate between between the top, which is the CIN, and the bottom, which is the squamous cell carcinoma. But as a clinician, we can use other important tool, which is the optical biopsy, meaning like the OCT. It's not a regular OCT. It has to be a high resolution with minimum of 5 micrometer. There are two machines that are available with the high resolutions. I have no financial interest, but what's the pros and cons and advantage of disadvantage of using the high resolution OCT? Yes, it's a non-invasive tool. It can help you in checking the resolution of the disease if you use a chemotherapy or post-surgery. However, it has limitation in the depth penetration because of the pigmentation and also in elevated lesions. And cannot distinguish simple squamous cell carcinomas from the highly malignant variants, which are the adenoid, the spindle, and the mucoepidermoid. When we reviewed the literature, and at the beginning, like almost 5 years ago, when we started to use the OSSETs here, we found that there are consistent 4 features if you are going to use the HRT. These features are the epithelial thickening, hyperelective epithelium, abrupt transition between the tumor and non-tumor, and the presence of distinct plane underneath non-invasive lesions. These are pictures are taken from these 3 big review articles. So, for instance, if you look at that lesion, the horizontal or vertical cut, you can tell that there is hyperreflectivity, there is thickening of the epithelium, and there is abrupt, transition between the normal and abnormal, and this is the zone that I'm explaining. The same thing also here. And here, a picture telling you the differences between UBM, the resolution, and HR OSSET. This is another picture. It will highlight the same thing, the epithelial thickening, reflectivity, the abrupt transition. It is similar, by the way, to the pathology. If you look into the pathology section, you will find the same abrupt transition and the zone which is here. OSSET is very important if you are using chemotherapy because it will help you to confirm the resolution. So this is the tumor, this is with the chemotherapy. It's completely gone clinically, but when you look into the OSSET, the lesion is still there, and after a few cycles, the lesions disappear. So in general, we know that the OSSET resolution takes longer time than the clinical, and that's very important for our treatment plan. The same thing also here in this picture. What about the KKESH patients? We try to apply the same thing after the visit of Carb to KKESH a few years ago. So this is one of the OSSETs. You can see thickening of the epithelium. We don't have the most sophisticated one, but this is what the best pictures that I was able to get to bring. And this is the abrupt transition. And you can see here the underlying zone. This is another one. By the way, these belongs to the one patient. You can see here. And this is by UVM. The same thing. You will see the hyperreflective epithelium in comparison to the others is less prominent, but in OSSET it will be more prominent. But again, it can tell you the penetration and the zone, as you can see here. That's the UVM. Another patient who have a very large tumor, and this is the OSSET, and this is the zone, and then transition. And by a UVM, you can even by UVM tell that this is intact sclera and intact cornea, and it's very obvious. And this is another one. So this belongs to KKESH patients. Follow-up after chemotherapy, the same thing. You can look into the lesion here before and after. There's still residual, but you can appreciate the differences in the size and also in the OSSET. UPM picture, again showing intact sclera, same features you can tell, okay. And the UPM for a large papillomatous lesion, and you can even measure it, and you can follow the patients with the measurements if you want after starting a chemotherapy to see the response, if you have any doubt. This is one of the immunocompromised patient. This patient having also some psychological diseases, and he could not have a surgery. Anyway, I started first with treating this necrotic tumor, and then I wanted just to make sure what is the situation before trying to convince him to go for surgery, because it's really highly suspicious of invasive squamous cell carcinoma. And you can see here the nodules very clear highlighting with this UVM. And it's not invading the sclera, but intra-op there was a fine line of scleral invasion. I had to do the sclerectomy. So this is Prof. Carp. She's a friend of most of the members here in KKESH. When she visited us in 2014, we started a long-term relationship with her, and we're seeing her in the academy and most of the cornea meetings, and she doesn't hesitate to give us her consultation if we need any. The orbital images is another thing that we need to keep in mind, but we don't do it for every patient. There are some patients who will refuse because, you know, CT scan and MRI is not a pleasant experience. And there are some signs that tell you that this patient needs to have the orbital images. The presence of tumors in the fornix or in the caruncle, tarsals, intraocular invading lesions. If you examine the patient by the fundus or by B-scan or UVM, presence of lymphadenopathy, and also aggressive subtypes if you do excision and you find patient belong to one of the 3 variants which I told you before. This is an example of orbital images for 3 cases which were done here in KKESH. This is the first one who had a very large diffuse tumor involving the caruncle, as you can see, with few pigmentations. And when we look into the patient's UPM, it's obvious that there is an infiltration into the anterior chamber. Here you can appreciate it because the tumor is really obscuring, but if you do gonioscopy, you'll be able to see it. So that's why it's gonioscopy, fundoscopy, the base things needs to be done for any patients with the tumors. And this is the invasion. You can see it here very clearly. Then we convince the patient to have an MRI with contrast, and the excisional limited excision was done to the patient for the sake of diagnosis, and you know that it is really invading the eye. I will tell you why, because the eye was full of hypopian tumor cells. But we need to give a diagnosis before moving into the next step, which is counseling patients to have subtotal exentration. So this is an invasive variant with the involvement of lacrimal sac by the MRI and medial rectus. So the oculoplastic team here, they did for the patient the subtotal exentration, including the periocular tissues and the lids, and the patient was referred to have a metastatic work. The second patient is 5 months post-excision of nasal pterygium, which was done elsewhere. As you can see here, when you look at it, you cannot tell what was the original diagnosis. And then when you just do an UBM, you will see a big mass underneath inside the eye with RD, and this is the mass appearing in the B-scan, and with the MRI also you can appreciate the tumor invading the globe itself. So this is an invasive squamous cell carcinoma with preauricular lymphadenopathy. So we looked into the slides for the tumor which was excised outside, and was studied carefully by our pathologist, who confirmed that that was a well-differentiated squamous cell carcinoma, and the oculoplastic team did for the patient lid sparing exentration, including the globe and the periocular tissue. The other patient, he's 1 month post-excision of pterygium. What he said was a pterygium. He came to us and saying that that was a pterygium, and it's located temporal. This is one of the suspicious location. And you can see here only, you'll just see an inferior blood vessels with some thickening, with somewhat look like a gelatinous appearance, but it's not clear what is it. It could be non-pigmented melanoma, by the way, or it could be OSSN. You cannot tell unless really you get pathological slides. And when you look into the gonio, you will see something, appreciate something pushing behind the iris. You can see here, and that the mass is involving the ciliary body, actually. As you can see here, it's a cystic mass, and with the MRI also proven that one. The conjunctival incisional biopsy was done for the remaining mass, which I told you, and it came to be invasive squamous cell carcinoma. Because it was involving the globe, and the patient developed a intraocular, and patient vision was a little bit poor, we offered the patient to have a brachytherapy versus inoculation. Patient refused total to undergo inoculation, and then he couldn't have the brachytherapy done, so he returned back with intraocular hemorrhage and total RD worsening, so inoculation was done with a conch resection. Metastatic workup was also done for this patient. What about the masquerading diseases? So some of these cases I'm presenting them as a challenging case in the cornea. So this is one of the first patient, 34, a young patient. He's healthy. That's false excision of limbal inflammatory lesion, was labeled as atypia, and that was 7 years ago. The patient was treated in the emergency room as a case of presumed dendritic herpetic keratitis. So this is the picture of the patient of the atypia, which was excised. And this is the picture 7 years ago. And then the patient kept coming to the emergency room and was treated as a case of dendritic herpetic keratitis. There are some whitish lesions, as you can see, if you can appreciate it also here. It took a long time to have healing, almost like 15 months. Later, patient presented to the clinic, and the surgeon who saw the patient diagnosed him as a case of limbal stem cell deficiency. As you can see here, you can see that there is whitish infiltrate of the cornea with a lot of blood vessels coming in. And here there is a marked thickening. This is more magnification. But if you look carefully into this frosted lesion, then you would say that there is something wrong. This is what we call frosted. Okay, so this, keep looking carefully into that one. It has a cauliflower appearance. This is my preferred description of the whitish infiltrate. Anyway. So, as I said, the surgeon diagnosed the patient as a limbal stem cell deficiency and with a pseudopterygium, and heated for the patient. What is usually done is CLAW, conjunctival limbal autograft with amniotic membrane. When he sent the tissue to the pathologist said that it was incomplete, and they found a lot of severe dysplasia of the cornea, focal area of carcinoma insider. That time I was consulted, and then I managed to do for the patients non-touch technique. So I've done complete excision of nasal conjunctival OSSN. I will show you the picture of this one. Okay, so I've done complete excision of that one, removal of all this corneal lesion, epithelial removal with alcohol, also done cryo. And this is the appearance of the patients. And then I started the patient on topical 5-FU, and this is the picture post-operatively. And the pathology confirmed that that was a CIN. So it was a limbal stem cell deficiency masquerading as a masquerading disease. So the extra thing that which I've done is that I run an HIV test, and it came to be positive. It wasn't astonishing, because with this age and with kind of aggressiveness and extensive coverage of the cornea, one should exclude the immunodeficiency status. These are another 2 isolated corneal OSSNs which I treated, pure isolated corneal OSSN, because we believe that corneal OSSN arises from the stem cell because of some problems with the tumor suppressor genes. Again, these are frosty looking lesions, cauliflower, I would say, some with keloid formation, but if I don't have a better picture for that one, and these are the pathology reports. Anyway, so another masquerading is for this young patient. She's 50 years, she's healthy. This is her right eye picture, and she kept on following because of long-standing chronic inflammation, and she was diagnosed as an atopic keratoconjunctivitis in the left eye. Look at it with severe limbal stem cell deficiencies. You can see with the fluorescein. 10 months later, the patient presented with these big nodules in the caruncle. So again, if you exercise the same and try to apply the same rule. If you magnify it, I didn't find really a true, but I saw the patient because I was consulted with this patient after that, after this mass development. There were some frosty lesions, you know, in the front of, you can pick it up here on the top, and the conjunctival thickening is not normal, and this is really a solid mass. So the patient had also an involvement of left medial canthal by MRI, and fortunately the patient ended up having exentration. Again, remember this eye, the right eye, which was free of anything, and this is the left eye. 1 year later, they was asked to examine this patient because she developed in her good eye corneal ulcer that's not healing, glue and everything. It was very simple. Just by everting the upper lid, I noticed there was a papillomatous lesion that was rubbing against this cornea, and that started the cascades of all the epithelial erosions, infections, and so on. So again, the patient was misdiagnosed and was subjected to the pathology. Okay, so again, the other diagnostic tools that we need to do is incisional biopsy. But the question nowadays, with all the controversy, with all the advancement of the OCT and imaging, do we still need to do incisional biopsy? Is it necessarily? Okay, so that's the reason why we need to do the incisional biopsy, because the incisional biopsy will give you accurate grading more than any other thing. Clinically, you cannot grade the CIN from the squamous cell carcinoma, as I mentioned, with only 40% accuracy. You can differentiate between different subtypes, the mucoepidermoid and so on, because they have a different way of treating them. You can also avoid misdiagnosis, especially if you're practicing in Western countries where a lot of non-pigmented melanomas may present as OSSN, especially in the gelatinous form. Okay, you can also detect and or anticipate earlier the orbital invasion if you have incisional biopsy. The other thing is that nowadays most of the ocular oncologists believe that the OSSN behaves in a way similar to the melanoma. It's a tumor with a low-grade malignancy. Yes, it's the commonest epithelial tumor, with a mortality rate that is increasing. In fact, I found one publication here in Saudi by Dr. Tabara, and 1 out of 10 patients who died from metastatic OSSN where it was reported. So that's a really high mortality rate, like 10%. And in Australia, where of course we expect much higher prevalence, also 2 out of 26, and in the United States was up to 24%. This is very similar to melanomas. So really, this will guide us to change our mind and start doing a lot of incisional biopsy in these patients. What about the clinical pathological correlations? What kind of grading system we're using? This is the conjunctival tumor grading, and that was proposed by the American Joint Committee on Cancer. This is the most updated one, the 8th edition, and you can concentrate on this one. This is tumor in situ, T1, T2, T3, T4. Just forget the other. Like T1 and T2 just is gonna tell you the differences of the tumor and the size itself. And then starting from T3, T4, it's the invasion itself. Look at T3. It's a tumor invades adjacent structures excluding the orbit, which means the cornea, it means the sclera, it's a very broad term. And then T4, if it involves the orbit, and this is the different part of the cornea orbits, including the brain. So, and how can we follow this one? Is it by just doing optical or ultrasonic imaging or MRI? No, it has to be done with confirmed histopathological specimen. You can just, in addition, for the invasion to the images which I showed you before. I found actually 3 important review articles discussing the importance of this classification system and how can we correlate it as a clinician. because we don't follow this one truly. The only thing that is of great help to us is that this kind of classification will tell us the risk of tumor recurrences and metastasis, because it's very accurate. However, most of the initial treatment of the carcinoma in situ is almost similar to the squamous cell carcinoma. And most importantly, the category T3 is not of help at all to the clinician in defining the surgical options, whether it's a diffuse or deep. This is the other solar eclipse photo 10 days ago, taken in Abu Dhabi. And I really feel sorry about the eyes of the camels and this Bedouin guy. I don't know how they protect their eyes. Okay, so what about the studies in KKESH? There were a few studies that were conducted in KKESH. One of them, as I said at the beginning, which was highlighting the tumor registry in KKESH, and the other one, which was done with also our colleagues in Johns Hopkins, and Dr. Sabah also was involved in that one about the DNA expression. And one of the clinical one, I've done it with my former fellow, Dr. Noura Al-Khareji. We did that one before the era of chemotherapy intentionally. I'll tell you later on why. So we've done the retrospective chart review of 88 OSSN. These are all the cases which were treated in KKESH between August 2003 and December 2014. And the minimal follow-up was 1 year. And we divided the patients into two groups, and this article is under review, into recurrence and non-recurrence. So the recurrence group was 23.7%, and non-recurring 76.3% of the whole population. So our recurrence was matching, by the way, what's been reported in the literature. Okay, and this is the mean follow-up for both the group at almost like 6 years. So the recurrence occurred in our patients at a mean of 25 months. So it starts from month number 2 till 95. So month number 2 till 7 years. So that's why we need to have the good follow-up. And then when you ask about the type of therapy, as I told you, that was before the era of chemotherapy. So most of these patients, or almost like 100%, were managed by surgical excision with or without adjunct chemo later on in the form of mitomycin only. Okay, so the positive correlation of recurrence was with corneal involvement, with higher pathological grading, and with positive surgical margins. Now, the treatment. The treatment is really a wide, there are a lot of variations. There are 3 references in the United States, in Cleveland, in Bascom Palmer, and also in Wells. And these 3 groups are treating the patients using different protocols, but the concept is almost similar, actually. I just want to summarize from what's available in the literature and also my limited experience over the past few years. So after that the clinical review of all our patients, and with the visits of Carl Karp, we decided that we need really to change our way of handling these tumors in KKESH to reduce the recurrence. 23% is still high. So this is what I proposed. So if the wall is not involved, okay, if the lesion is less than 3 to 4 o'clock, you can do surgery or chemotherapy. If it's more than 3 to 4 o'clock, you can do chemotherapy, or you can do chemoreduction for a minimum of 3 months, followed by surgery. And if the ocular wall is involved, sclera. If it is partial, then you can do sclerectomy, cryo, then chemo, and or better if you have an access to the brachy. And if there is an intraocular, it depends on the visual prognosis. Can go for brachy or inoculation, and if the orbit is involved, then exentration is a must. What about surgical versus non-surgical modality? I noticed one review article that was trying to appraise all the case series that describe OSSN. I would say case series because truly all the managements that we're following are based on case series. There were none differentiating the medical versus surgical. And this is the most important thing to know. So that's why it's the your experience plus the SK series that will define your protocol. Anyway, the quality of life. What about if surgical versus chemotherapy? There was one good comparative study, and it was prospective, and it looked into the patients who underwent a surgical excision versus those who received an interferon topically. And the experience of pain was much higher in surgical group, but less ocular symptoms and irritation from the chemotherapy. And what's important is that both the groups said that they are satisfied with their treatment and were the functional recovery 1 year after completing it. What about, again, checking the Cochrane database? I found only 2 randomized control trials describing limited chemotherapy protocols. The first one, it was mitomycin versus a placebo, but that was, of course, only for CIN, not for the invasion, because you cannot just put a placebo to a patient with squamous cell carcinoma. And incisional biopsy was done prior to that one, and then they checked the resolution, and there was a marked resolution when you used the CIN and mitomycin in comparison to the placebo. That was just the first one, and we know about that one. We know that the mitomycin is extremely effective. The other one was trying to study the importance of using 5-FU in all patients who have OSSN in Africa. As I said before at the beginning, 70% of these patients are HIV positive, and in HIV positive, most of the pathology are going to be in T3, T4 category. That's number one. And the other thing, they're rapidly growing, and they have some resistance to chemotherapy, by the way, in particular interferon. So what they did in Kenya is that they've used the 5-FU for all their excised tumors for a period of 4 weeks for one group, and the other group placebo. But they've done like 4 millimeter early free margin. They've used all the protocol carefully to avoid any recurrences, but they use this medication as what we call chemoprophylaxis. And when they follow up the patients in that randomized trial, they found that the recurrence was 36 in those who received only placebo in comparison to the 5-FU. So those are the only 2 clinical trials that I found. Okay, now, what about the recurrence? The recurrence, if you choose the surgery alone, or if you're going to use the chemotherapy alone, or if you want to do the surgery, then chemotherapy. These are the 3 protocols that many of us are following. If you still believe in doing only surgery, just to let you know that the recurrence was reported from 1552 and KKESH was 23% long time ago. If it is negative margin, 33%. But what are the possibility of an experienced surgeon having a negative margin? Truly, it's probably like 10% when we discuss it with all the corneal specialists in the meetings. Positive margin, the recurrence rate up to 56%. So another thing is that for surgeons who are just excising the tumor without doing a proper cryo or not taking precautions of the epithelium, on the other hand, they tend to have a high recurrence rate, up to 39 versus 9%. What about chemotherapy as a primary tool to treat OSSNs? If you use mitomycin from 0 to 15, 5-FU 6.7 to 11.1, and interferon 3.7 to 5%. Anyway, we know that there's a long-term follow-up for mitomycin use as a primary medication. For 5-FU, all the publications are for short-term follow-up, maximum of 5 years. The interferon is a little bit higher. So one would say that I can use 5-FU or interferon if I don't want to use the mitomycin that have a higher rate of recurrences as a primary medication. What about the doing surgery? Then a chemotherapy. You can do surgery, then mitomycin, and the recurrence is 0 to 30%. If you do surgery, then 5-FU, it's from 10 to 15. If you use surgery and then use the interferon, it's from 0 to 28%. What are the cons and pros of doing surgery? The advantage of doing surgery is that it's a treatment of choice if you have a small tumor, less than 3 to 4 o'clock. It's a treatment of choice in invasive OSSN, partial scleral adhesions. I'm not saying penetration. Treatment of choice in rapidly growing lesions. Treatment of choice in immunocompromised patients who cannot have a lot of clinical follow-ups or medication refill, and if there is an issue with the compliance on the drugs, except for a possibility of short-term adjunct therapy post-op. What about the disadvantage? There are patients who don't like to have surgery because they fear. I've seen some patients whom their family members refused to tell them that this was a tumor, and I was forced to use chemotherapy until they break up the news to them. The cost also, it was calculated in UK, and it was found to be much more costly in comparison to the chemotherapy. It requires also an experienced surgeon really to handle it. It's not 1 or 2 free margin as it used to be in the past. It has to be a minimum of 4, and we have a rule of 6, 4, 2, 2. So at least we have to have like a minimum of 6, maximum of 6 o'clock of cryo, 4 free margin, 2 millimeter of the away from the scleral attachment, 2 millimeter from the epithelial edges, and so on. And conjunctival scarring symplepharon can happen in large tumors, scleral melting, stem cell deficiencies also can happen, causing corneal blindness, especially in large tumors if you want to do the surgery. I promised Dr. Azza, she couldn't make it today because she's on leave, to show up this. So basically, when we have a tumor, we always communicate with her or any pathologist who is available on the week of surgery, and we managed to come up with a certain drawing. The orientation is very important. The reason behind is that this will guide us about the post-op course. So, like for instance, for this patient with a big nodule, draw it, and then you have to put the eye and the nose, and because they have to orient whether this is closer to the nose or way, nasal, temporal. You cannot tell just nasal, because nasal to her is nasal this or nose. This is not clear. And then you have to put 2 sutures to orient the superior from the inferior and so on. And if there is any scleral removement, you have to send it separately. So this is the way how the pathologists prefer to follow, especially in Wells. What about indications for topical chemotherapy in non-invasive OSSN? It can be used alone if you have more than 2 quadrants or more than 180 of limbal involvement to avoid limbal stem cell deficiencies, clear corneal extension, especially those covering the pupillary axis, patients who are not fit for surgery or who are still in denial, recurrent non-invasive OSSN, immunocompromised patients, post-excision, and multifocal lesions, and when you have positive margins. So what are the chemotherapies that we have? So far, we can use interferon, we can use mitomycin, 5-FU. Other medications were used for, in any case reports, cidofovir, anti-VEGF, and aloe vera, and their efficacy is still under question. The interferon, whether topical or intralesional, that's a big controversy. And what are the mechanisms of action of each of these chemotherapies? Very important, and the cost. This will guide you in deciding which medication you're going to use for your patient. For instance, mitomycin, which inhibits gDNA and mitosis. The cost is $200 per bottle, and it has a lot of side effects, as you know, corneal erosions, stem cell deficiencies, punctal stenosis, and you need to put a punctal plug even before starting this therapy. What about the 5-FU? This is a very gentle medication that inhibits the DNA and RNA. It has no resistance, and tolerability is reasonable. Corneal erosions can happen. The third medication, which is the interferon, alpha-2B, the interferon inhibits mitosis, and it is the most gentle medication on the ocular surface, but it has some systemic side effect, like flu-like syndrome and fibromyalgia when given intralesionally, by the way, okay? And there's some reports of resistance to it, and this is the cost. This is one of the most expensive one. Now, whether to go for topical versus injection, of course, this is the reason behind. Refrigeration is needed for mitomycin and for interferon, because these medications are not stable, but the 5-FU is more stable. What about the KKESH cases? So I'll give you just a couple of cases that were treated here over the past few years. The 5-FU was used as a single treatment in one of the non-invasive tumors. You can see here how many quadrants the lesion, and it's also covering the pupillary axis. There is no way that if you're gonna excise this tumor, you will remove the whole stem cell with a free 4 millimeter, margin. So you probably will end up having only just one clock of the stem cell. So use 5-FU alone, and this is the appearance, marked improvement. Look at this picture. And here, after 2 cycles, only 5-FU, after 3 cycles of 5-FU, and after 4 cycles of 5-FU. And this is the picture of the patient 2 years after diagnosis. Another patient, the patient who had a nodular mass, it's large, it's in the involving the punctum. There's no way that you can guarantee a free margin, so the excision was done, but free margin still is not possible in some areas, especially inferiorly and nasally. And the pathology report came with squamous cell carcinoma, and this is the appearance. And then the patient was subjected to an injection of interferon. He received 5 injections, and this is the appearance after, just to avoid a recurrence. And the patient was free of recurrence after 2 years. A chemoreduction also can be used in a large tumors. Not only one medication, we can use 2, especially in a very thick one, and in patients that you may not expect a patient to clear for surgery soon, to speed up the resolution. So this is one of the thick tumors, and it's covering the cornea. And after 2 pegylated interferon injection, 2 cycles, you can tell the difference, how much change in the size. And after 7 injections, the size totally shrunk. Patient refused the surgery when we discussed with her, and this is the follow-up of the patient after the last injection. So the follow-up was 1 year after diagnosis, and you can tell the marked differences. So interferon injection with 5 cycles of 5-FU, no stem cell deficiencies at all. As you can see, one would expect if you use a mitomycin in the eye after 1 year to be really an angry looking. Another chemo reduction with 2 medications. Sometimes you need to do it for some of the patients. As I said, look at how extensive is this, and this is the appearance before and after 2, after 3, and after 5, and the patient booked for surgery, but the patient so far did disappear. Another patient who had an excision, and then the tumor recurred, and this is the appearance, and it was also involving partially the fornices. And after just 3 months of the injection, you can see the marked improvement in the lesion itself. Some of the tumors in the past, like this, was presenting to us. We had no way, especially the superior one, the drops was not going to work very efficient. Injection, where to inject, you have to do some debulking, and then to continue with the chemo. It's a reverse, and this is what happened. And we know that there is a residual tumor, and then we treated it up completely with the interferon. So, is there any specific protocols that anyone is using? It's not, because it's a really variable, based on the patient themselves, based on the experience of the surgeon, and the general condition. So you have to keep updates yourself with what's available, and to read every now and then, discuss all the modality of treatment. Like here in KKESH, we present all OSSNs to the CTR, and we have a group discussion. So in conclusion, I would say that OSSN makes sense or presents as a cellular growth on the cornea, frosting lesion, and staying well with rose benga. Diagnosis of OSSN is confirmed by incisional biopsy. Other investigations are required prior to starting chemotherapy or surgery to exclude invasion, especially OCT, UBM, with or without MRI. Non-touch surgical technique needs to be performed by an experienced surgeon, and proper tissue handling and orientation is very important and is requested by all the pathologists. Chemotherapy is becoming the favorite approach in the treatment of OSSNs, especially for diffuse, multifocal, and recurrent cases. Clinical resolution size precedes those obtained by incisional or optical biopsies by at least 1 to 2 months. Ophthalmologists need to consider patient preferences, patient compliance, the status of ocular surface, the costs, general condition, access to care, refill of the medication when deciding on the treatment approach. And thank you for your kind attention.
Thank you, Summer. This was a very nice review of the whole subject. If I may say, the first step in all of this is to suspect carcinoma when you see it. So the suspicion is the first step for the diagnosis. Do we have any questions?
Thank you, Samar, for your excellent presentation. I'd like to welcome Dr. Sabah also, as a coordinator. It is your home. I just enjoyed the presentation, but I would like to know what's the protective or preventive measure? Because we are in sunny area, and could sunglasses protect it? Could lubricant prevent it? Or it is not avoidable?
Yeah, for sure, ultraviolet is one of the mechanisms of development of OSSNs. And in regions where the ultraviolet exposure is very high, especially in Australia and sub-Saharan Africa, they tend to have a much higher frequency. So we know that we need really to ask the patients to put on a UV, especially if they started to have some changes in their conjunctiva in one eye, also to prevent it from the other eye, and tell other family members. The other thing is there are some genetic predisposition in the literature with something called tumor suppressor gene. If there is an activation of that one, then the tumor will go. We don't know exactly what activated it, but one of the possibility are viruses like human papilloma virus and so on. So UV alone protection is not gonna prevent Saudi patients who are living in deserts from having the tumor, but also there's some genetic predisposition, immunocompromised status, and viruses and so on. But that's something. Anyway, because the subject today was about only diagnosis and the management, I did not address the etiology, but that's a well-known thing.
Just one more question. I didn't know if you mentioned anything between male to female ratio, because I was busy with
That's
my
a
mobile.
good question. Yeah, actually, I didn't put it in the slide, but one of the good studies that they addressed the likelihood of CIN to become a squamous cell carcinoma was in men patients. However, OSSN is much more common in women. I don't know how to tell that one, but these two studies are well known to us, and we have the references, and we know that if the patient is a man and we have a CIN, we need to be a little bit more aggressive, and we tend to see a lot of women, although the women are covered again in this society, but I noticed there are true, and this is in accordance with what's been published in the United States and also in Africa. So the gender, yes, but hormonal changes, I don't think so. That's the only reason. There is something wrong. So aggressiveness versus the presence or non-presence of the tumor. Yeah, go ahead.
I just want to ask one question. You said there is a high positive margin, even with experienced surgeons. Do you think we should revise the protocol? Instead of 4 millimeters, we should go more or less? And is there a specific reason for this positive margin?
So If you remember, Sabah, when we, like in the 90s and early 2000, the free margin that most of the cornea surgeons were doing was 2 millimeter. And the pathologists wanted to have more and more and more. Taking more than 4 millimeter does not guarantee that you're not going to have a positive margin because it's still being reported. But this is according to the American Joint Committee on Cancer, that we need to do at least 4 millimeter free margin of melanomas or OSSM. So that's what we are doing, 4 millimeter. That doesn't guarantee it. But is the recurrence rate decreasing? Yes, in comparison to 2 millimeters. So at least you need to do 4 millimeter. Doing more than that one, of course, will give you more complications probably, and it's not recommended. Yeah. Sarah, can you give her mic, please?
Thank you, Doctor, for your lecture. My question is, when is it safe to perform intraocular surgery for treated patient treated OSSN, and then later he required like cataract surgery or whatever? When is it safe to go for intraocular surgery?
Yeah, that's a good question, truly. So if you notice that most of the recurrence occurs in the first year, in general. So what I do here, and when I ask also my colleagues, is that I know many of them are old. We try to postpone it for at least 1 year after the last chemotherapy. 1 year at least. This is the agreement. Any other questions? Yeah. Okay. So for the first question is that
to combine.
why to combine two medication versus one single?
When to combine? You have special criteria when to combine two chemotherapy instead
Two
of one.
chemotherapy. As I said in that slide, if the lesion is very thick and large, okay, and you want faster resolution, and you have a question of the resistance, which occurs especially with interferons, then you need to combine and use two medications. This way of management was started by Karl Karp almost like 2 years ago, and then we're following also the same thing. It's a small case series, but it's showing faster response. This will reduce the compliance and it will improve the outcome. So that's when you choose it. Of course, we're not talking about mitomycin because 5-FU is less irritant, and the interferon also intralesion is less irritant. So we're not talking about combining two toxic medication. We're talking about combining two gentle medications on the ocular surface. The second question, xeroderma. Xeroderma, they tend to have a lot of recurrences, and just doing surgery alone, it's similar to the HIV patients. So doing surgery alone without adjunct post-op chemotherapy will increase the recurrences. And because they have problem in DNA synthesis, and part of the etiological causes of development of this OSSN is related to the DNA synthesis, they tend to have new tumors. So you cannot keep on excising, so you have to be gentle on the ocular surface. So chemotherapy is really a good option in these patients in general. Yeah. Any other? Yeah.
Thank you very much, Doctora. Two questions. The first one, maybe a couple of years back, we remember Shields and Shields, they were mainly treating patients without getting biopsies, if I still remember very well. I don't know if this is, with the years, has been changing.
With biopsies?
Without
biopsies.
Without taking biopsies. So the diagnosis is mainly like clinical, and then they start chemo reduction or chemotherapy. I don't know if this is still applicable nowadays or not. So I need your comment on that.
Thank you. In Karl Karp, Shield and Shield, it's true. Both of them nowadays, they are, and still until now, they're treating their patients without incisional biopsy. However, my clinic, it's a must until now. These are the three groups, the largest referral oncologist center for OSSNs in the United States. That's the first one. The second thing, do we still need to do incisional biopsy? Tell you the truth, nobody can compete with Shields or with Carol. They are seeing more than hundreds of cases. So they can tell you there are likelihood of this to be carcinoma in situ or squamous cell carcinoma. And they tend to have a frequent follow-up in their clinics, so they observe the resolution. If they notice that the patients are not responding very well, they become highly suspicious, they will stop and they will do incisional biopsy. And that's what we do also here in KKESH. So we sometimes don't do the incisional biopsies in diffuse lesions that are very clear, but we tend to do incisional biopsies for those lesions that have questions of invasion and probably likelihood to penetrate. Because if you leave a patient for a couple of months on chemotherapy, the tumor may invade. So this is the question, and so this is the most important thing. You're subjecting him to long-term chemotherapy, but at the end, you are delaying also the proper management.
Second question.
Go ahead.
Do you have? Can you share with us some of your experience with the forniceal lesions, or at least from your
Yes.
KKESH experience, or from the 88
I show one of the
patients
examples, yes, one of the forniceal. The patient underwent an excision of the tumor, and then the recurrence was at the site, and also it was in the fornix. And because it's a fornix, that's a nice location for chemotherapy topically, and also for the conjunctiva nearby also. So we were injecting intralesional for the one next to the limbus, and we were applying 5-FU as drops. So yes, but again, if you have a forniceal involvement, MRI is a must before starting this regimen. Orbital invasion is very high, and I usually consult chiroplastic team. Any other? Yeah.
Thank you so much, Dr. Samar. My question is, if Dr. Carol isn't taking the biopsies initially, we know interferon doesn't work very well with amelanotic melanomas, but it works with the squamous cell carcinomas. Wouldn't it be advised to start with a mitomycin if I don't have an incisional biopsy to prove my diagnosis, rather than starting the interferon and losing precious time if it was amelanotic melanoma?
That's a good question. True. Like in 2016, I presented that case with the first one in the eucornea, and she was present. And it was the first time that we noticed that there was a resistance to interferon. And I had it here in KKESH, and also she had a couple of. So the resistance is true in patients with HIV. But the agreement is that we don't like to use mitomycin. The recurrence rate is still high, by the way. It's very toxic. So we're using 5-FU instead of. 5-FU is one of the most safe medication, especially in immunocompromised. If you notice the clinical trial in Kenya, they're using 5-FU. Another thing is that the cost, by the way, it's not very expensive. It's even less expensive than the mitomycin. Tolerability. So there are many things that would lead you to use the 5-FU besides the case seriousness, besides your experience. It does not require a refrigerator. It's a short-term course in comparison to other medications. So in comparison even to the interferon, by the way, interferon, you need to use it for longer period. Resolution takes longer time. So 5-FU is the best medication for immunocompromised patient. Yes. Okay. You want me to ask? What is the differential diagnosis if you have leukoplegic lesion? Actually, the reason behind is that, you remember 2 months ago, 2 or 3 months ago, one of the fellows presented an leukoplegic, lesion close to the limbus. And they disregarded the number one also differential diagnosis. Can anybody tell me what are the differential diagnoses for leukoplegic lesion? Apart from OSSNs, any leukoplegic lesion in the conch. Yeah. Pitote spots, vitamin A deficiency. Yeah, that's one of the differential diagnoses that needs really to be addressed. So we have to be careful. And if you have a doubt, then of course, we would advise just to take a biopsy and then to tell this is a pitote versus OSSNs. Okay. Yeah, keloid, like the picture that, yeah, in that patient with corneal abscess, and sometimes the keloid will cover the corneal lesions. So you have really, when you, to be careful when you examine patients with keloids, especially those who have symptoms. And also use rose bengal. It's a very important.
Are not leukoplegic.
Are not leukoplegic, yeah. I thought she's asking. Huh? Zudo? Yes, that's also one of the things can be used, yeah, as a differential diagnosis, correct. What's your question, Sabah? About the
I just want one of the fellows to tell me what is a good cryotherapy. We're talking all the presentation about good cryotherapy, so can one tell me what is... So why do we do it double toe? Why double? And what is the difference between the freeze and toe?
Yes. You know the answer, right? You're a fellow?
No.
Okay.
Okay, please say, yeah, please.
I believe, and excuse me if I'm wrong, the difference between the freeze and the thaw. The thaw is the time that you allow the machine to cool off the tissues, and we do it. It's more important than the freeze itself because you allow the ice crystals to become more sharp and damage the cells more.
Good, thank you. Because many people believe it's the freeze.
Okay. The other thing, can we repeat the cryotherapy? That's the question that that was raised by some of the colleagues. Can we repeat cryotherapy? Any retina colleagues can tell us what are the disadvantages of repeating cryo on the base? Okay, so basically one of the non-touch technique, we need to do a cryotherapy to the base if we notice the tumor is adherent or attached a little bit, I'm not saying invading, attached to the tenon itself with the tumor attached to it. And we have to do to the base, and we have to exceed that one by 2 millimeters with partial scleral removal, okay? But that usually we do it once. If you repeat it twice, then there is a high risk of complications. So anybody from retina can tell us what are the things that they don't like. They will tell that will subject the patient to hemorrhages, I think. Anybody here can tell? Marco? Or anybody here? Sleiman? So that used to be that used to be a practice in the past to repeat the cryo on the whole bed of the tumor if they have a recurrence. Now they don't like it. And the retina specialists, they are asking us not to do that one.
You mean effect on the posterior segment?
Yes.
So you can cause, if not careful, if you don't really put PSS while you remove your cryo and you wait for the defreeze to happen, you can de-roof sclera if it is, and you can open if it is very thin. This is one thing that is a rare complication.
Scleromalacia.
Yeah. You will cause chorioretinal scar if you are more posterior in your cryo.
Ischemia also, necrosis.
No, if it is not extensive, I don't think it will lead to this.
Hemorrhages also was reported by UK group.
Yeah,
Yeah?
Definite.
Definite?
Yes,
Oh.
it can happen.
Okay, I see. It's a good thing. Any other questions? Yeah, Faisal. Thank you. Thank you, Dr. Sleiman. Faisal. So, which medication? Yeah, which medication? You're talking about minomycin, huh? In particular? Okay. So, for the interferon, the agreement is that we do QID We'll continue with that one for a minimum of 6 months. That's topical interferon. There is no off period for interferon topically. For 5-FU, there are 2 regimens. One used by Bascom Balmer, which is 1 week on, 3 weeks off, and also by Mayo Clinic. The people in Wells, Shields, they're using 2 on, 2 off. This is the regime. In UK, also, they're using 1-3. So there are no agreements. Even when you look into the case series, you will see there are no agreement in the 5-FU. But at least 1 or 2 depends on the toxicity and tolerability and how much you want to give the patient. That's for 5-FU. Anyway, it's a tolerable medication. The mitomycin is the one that is really, there are a lot of variations. Depends on the subvariant and what are treating. If there is positive margins, usually they like to go for aggressive by the way course. Aggressive meaning like 3 on, 3 off, 3 on, 3 off for a minimum of 3 cycles. If you're just doing it as a prophylaxis, then you can go for 1 on, 3 off. That's a second regimen that you can use. If you're treating your patient with a larger tumor, then you need to balance also the ocular toxicity. But these are the regimens available in the data and by these people who are practicing. The steroids, that's a good thing. The steroids is a must with 2 medications, the 5-FU and mitomycin, with lubricants. And sorry, the punk, which one? Yeah. For the mitomycin, it has to be free, but for the 5-FU FML. Yeah. Any other questions? Yeah, thank you.
Just I'd like to ask the fellow, first year fellow, second year fellow, and consultant to apply that to the TOT, which will be conducted in February. Training of the trainee. It's one of the requirements for this hospital. The session will be on 15, I think, February. It's a full day, 8-hour credit to be considered. Those ones who already been certified, like Dr. Sausan Noilati, which is certified online, doesn't need it, but it's no more available on the line. They have to attend the courses will be conducted by the Saudi Council for Health Specialties. It's a mandatory requirement.
شيء نفتح بعدين نحط على الترزات عشان ما نشوف شغل. الاوتلوك صح دكتور؟ قصدي هي هتفتحينها بس هتفتحينها من البراوزر يا دكتور. طيب بس هو اليوزر نيم. مش نفتح شوف عادي صح دكتورة؟ صح نزل كامل دكتورة؟ نزل كامل كامل صح؟ يعني أفضل من اليمين حقك دكتورة خلاص؟
شكرا. Okay, we'll start the quiz. Okay. Okay, this is the first question. This patient is 5 years old, post-cataract, 5 years post-cataract surgery with this finding. So the first question is, what's the diagnosis? Mention 2 risk factors and 2 intraoperative preventive measurements. And bonus question, what's the management? Okay. The second question, this patient is 15 years old, post-pars planovitrectomy for retinal detachment, presented to our clinic 8 months post-op with this finding. So the first question, what's the diagnosis? And mention 2 or 3 steps in surgical approach. Yeah, the approach surgically, how to approach this case surgically. Okay. So the third question, this patient is 60 years old. He's 7 years post-cataract surgery, presented with the drop of vision over 2 years. So the first question, and this is the slit lamp photo. So the first question, I need 2 findings in the first 2 pictures. and the name of the slit lamp illumination technique in this one. Maybe it's not clear in this picture. Just focus on this one. I need two findings in this picture. And the slit lamp illumination technique here. Two findings in this picture. أتوقع أنها في التيفيز أوضح من البروجيكتور. معي إيه بس الإضاءة ما هي كويسة. And the slit lamp illumination technique in this picture. Yes. And the bonus question is the steps of management. Yes. Can I check the TVs? Is it clear? Just comment on the cornea and if there's something in the AC. Okay. So this question, this patient is 30 years old. He's post-refractive surgery. Okay, is it clear, this picture? Yeah, he's post-refractive surgery. So the first question is name of the procedure, the full name of the procedure, without abbreviations, please. And the second thing, mention two findings in this picture. So the name of the procedure and two findings. It's the same eye, but this is retroillumination. And he had, you know what's refractive surgery? Yeah, so what's this? At least mention one finding. Would be fine. It's clear. This is a slit lamp photo. هذا الcornea. This is the cornea. This is the AC, and the pathology is here. Not clear? No? The question is the name of the procedure. He had refractive surgery, okay? So what's the name of the procedure? Is it like refractive laser, LASIK, or other things? And this is the retroillumination. The other one, yeah, this is the corneal reflection. Maybe you see it more in the TVs. You can see the corneal reflection. This is the AC, and there is like something here. Okay? Okay. This patient is 29 years old lady. She wants to get rid of glasses. This is her refraction. In the right eye, it's minus 8.75, minus 1.5, axis 10. The left eye is minus 8, minus 2, axis 155. And she reached 2020. This is her pentacam. Okay, this is for the right eye. If the numbers are not clear, let me know so I can read it for you. What number you want to know? Yeah, no, not posterior elevation. She wants to get rid of glasses. Which refractive surgery is good for her? Is it corneal versus lens-based refractive surgery? And why? Are you going to do for her laser vision correction? She's minus 8.75 in the right, minus 8 in the left. Okay, so topography, this is for the right eye. K1 is 42, K2 is 43. It's 480. Kmax is 44. 3.24. 3.24. 3.24. Okay, and this is the left eye. K1 is 42, K2 is 44, and what do you want to know more? 29. Her refraction is minus 8. Okay, and this is her topography. Okay. So the question is, are you going to choose corneal or lens-based refractive surgery, and why? Corneal means laser or LASIK, or lens-based refractive surgery. The AC depth here is 3.21. Okay. This is the left eye. This is the right. Sorry? Which eye? The central thickness in the right eye, it's 480, left eye 475. Do you want me to repeat any question? The first one? Yeah. This patient is 5 years post-cataract surgery, presented with blurry vision, and this is a slit lamp finding. So the first question is diagnosis. 2 risk factors, or 2 eye conditions that can predispose to this condition, 2 preventive measures intraoperatively, and bonus the management of this case. Three? Yeah. So this is the third one. The second one, this one, he is 15 years old, post-vitrectomy for retinal detachment. So I just need the diagnosis and 2 or 3 steps in surgical approach. Okay, so this is the third question. This patient post-complicated cataract surgery, and he had good vision and then started to drop for 2 years. he came with these findings. So I have two findings here and there. And this is the slit lamp photo. I need the slit lamp technique for this picture. Okay. So this patient had refractive surgery. This is the fourth question. What is the name of the refractive surgery? And two findings. I need the full name, please, and two findings in this picture. This whitish line can give you a clue. Okay, and this is the last question again. Minus 8.75, minus 8, and this is her pentacam. Which refractive surgery are you going to choose for her, and why? Okay. Can I have the papers, please? Can I have the papers?